pleasure to be here. So I'm going to talk today about access to medicines, and I try to give a global perspective, meaning I'm not just focusing on my work internationally, but also my work domestically, and really trying to draw parallels and help all of us see that the issues that we deal with around the world are very much the same. So it's a pleasure to be here. I have no conflicts of interest. So a couple of learning objectives for this talk. I want to recognize the global challenges of access to medicines with a particular emphasis on chronic conditions, to appreciate efforts being taken to address access on the global stage, and then to learn about some tools that can help physicians and patients address cost-related medicine access barriers really here. Just a raise of hands, who's a clinician in the room? So I know who I'm talking to. Okay. Formerly part clinician. Okay. But who's a patient in the room? You all are. You all are. Okay. All right. So this will be relevant regardless of your perspective.
Patient of what?
Well, yeah. So I'll start by talking about generalists as globalists, talk about a case, a bit of my own personal journey just to give some context. We'll talk about the medicine access cascade, as I call it, and use a framework of the 4 A's of access to really think about a global perspective, as I mentioned, and thinking about addressing cost of medicines in clinical practice here. So this is just a piece that some colleagues, friends, and I published last year, 2 years ago, in the Journal of General Internal Medicine. And it was really a call to action for general internists to think about opportunities to think of themselves as globalists. Just read this. The credo of the generalist physician has always been about the promotion of health for all in every aspect, not just multiple vulnerable organ systems, but multiple social, cultural, political factors that contribute to poor health and exacerbate health inequity. In recent years, the field of global health has also adopted this same mission, working across both national and clinical specialty borders to improve health for all and end health disparities worldwide. I don't think this is new to anyone in this room, but just helps to sort of frame my perspective as a generalist. And then, of course, I think you all are probably well aware of Dr. Copeland's work in really helping us define this field of global health as thinking about health equity between and within countries, leveraging multiple disciplines, not just health sciences, bridging population and individual level care, and particularly emphasizing transnational issues and solutions. Just one other concept before we move forward is this concept of reciprocal innovation. And I bring this up because as I started to speak, I talked about the shared challenges that we have, right? And so Francis Collins saying global health should be a conversation with other countries, not one in which the great U.S. tells the world the answers are what the answers are without listening to and learning from their experiences. Obviously, this is fraught with emotion in this very moment, but I think still rings true. But the notion of we have issues everywhere, we have solutions everywhere, and we should learn from those. So I'll start with a very brief case. I attend on the general inpatient medicine units at Yale New Haven Hospital up in Connecticut, and a few months ago was seeing a 66-year-old woman, fully independent. She had uncontrolled diabetes and ulcerative colitis. She was admitted with multiple complications, infectious complications, and very high sugars. She's on 2 immunosuppressant medicines and a number of insulins and other meds for diabetes. And the residents had seen the patient. They came to staff with me, and they told me she recently stopped taking her insulin. And I asked if she told them why. And they said, we didn't ask. And so we went back to the bedside, and I said, I heard from my colleagues that you recently stopped taking your insulin. Can you tell me why? And she said it was either food or insulin. And this, of course, is something that I think anyone who practices anywhere in the world has heard or has dealt with their own family members or friends. And I said, I'm sorry to hear that. So many people face similar challenges. Have you talked with your doctors about the cost of insulin? And she said, I didn't. I was embarrassed to ask. I asked, have you been checking your sugars? And she said, I was just watching the numbers rise until I got fed up. So we know that in this country, Americans spend far more on pharmaceuticals than anywhere in the world, upwards of, on average, hundreds of dollars out of pocket per year. But around the world, out-of-pocket costs are high and rising. Excuse me 1 second. Okay. And in terms of this patient, an issue or a concept to be cognizant of is cost-related non-adherence. So when costs are high, people tend to not adhere to the medicines that they're prescribed. And in this country, 18% of all adults report not filling a prescription in the past year due to cost, and 1 in 5 with diabetes report rationing their insulin. And many cost coping strategies exist. I'll talk more about those. It's just a very humbling to look for a moment at this perspective on the 100th anniversary of insulin, where the authors wrote, the members of the team that discovered insulin sold the patent to the University of Toronto for $1 because they felt that the drug belonged to the public. And nearly 100 years later, it's really out of reach to so many people due to cost. So the scope of the problem is great. At least 50% of patients in the United States are non-adherent to chronic medications. 2 out of 3 medication-related hospitalizations are due to non-adherence. But again, I want to try to take a global perspective. And so I'm going to shift, and we'll sort of go back and forth for the next hour between work that I do in Uganda and work that I do here. In terms of Uganda, just to orient ourselves, country in East Africa, about the geographic size of Oregon with about 12 times the population, and about half living on less than $2 a day. A lot of reasons why Uganda, unfortunately, has been in the news over the last few years between the Anti-Homosexuality Act and political violence and Ebola outbreaks. But Uganda is also known as the Pearl of Africa, and it's a beautiful place. And I have worked there for 20 years because I love the people and the place. And some shots of my family, my children, and some beautiful locations. So just to think about some vital health statistics, just painting the picture again. HIV, TB, and malaria, among the highest burdens in the world, but relevant to this conversation, the prevalence of hypertension is high and rising, as it is throughout the world, about half the prevalence of the United States, and diabetes as well, as in many low-income countries in sub-Saharan Africa, quite a bit lower than middle or high-income countries, but all estimates point to large increases over the next decade. So I'd like to just pause to help you understand why I talk about Uganda and why and when I started there, and just contextualize this a little bit. 2004, I was in the first cohort of the Fogarty-Ellison program. As a medical student, I was sent to Uganda to partner with an ongoing collaboration on tuberculosis, and that's a picture of a much younger me doing some teaching to community about how to collect sputum samples. We were engaged in a community-based study on tuberculosis. But in that same time, I started noticing, along with colleagues, and on the right is a good friend who was my twin, who's now the chair of internal medicine at Makerere University. And we wrote this medical student paper, or piece in a medical student journal, about the great shadow cast by HIV in developing countries, right? So at that point, these were in the earlier days of global funding for HIV, and folks with HIV were cared for, the systems were being built, the providers were trained, the labs were there, and the medicines, importantly, were free and fully accessible. Yet, what we painted the picture of in this case presentation was that of a man with HIV and comorbid myocardial infarction who presented to the National Referral Hospital, where Sari and I have both worked, and was unable to get basic care for that MI, right? So this was in my very early days and has really shaped a lot of my thinking over the years. Actually, sorry, I didn't realize, there you are, right there, 2008. So would go back, again, these were in our days of residency, training, and Yale and Makerere University was developing an educational collaboration that is still vigorous to this day. So the opportunity to continue to return, I had to include this picture of Dr. Hassan at our graduation from residency in 2010, and then was able to return again as a global health chief resident, where I worked alongside a Ugandan nephrologist who had trained at Yale named Robert Kali-Subala, and really became aware of the great burden of renal disease from really hypertension and diabetes, right? Whereas when I went into it, I expected to see HIV-associated nephropathies. That's not really what we were seeing. So again, this is what I was seeing firsthand. And on the global stage, at that moment was also the first high-level meeting focused on NCDs. This was a really pivotal moment in shaping my own thinking, seeing what patients I was taking care of in Uganda, and knowing that this was part of the discussion happening globally. So there were a lot of important messages that were starting to come out at that moment around the high percentage of global deaths caused by non-communicable diseases, most of which being in low and middle income countries, and most of these being premature deaths, and really, driving home this double burden of disease that countries such as Uganda were underprepared to deal with. Really, a lot of fragmentation of care became very evident. And so based on that and this sort of conversation that was building, my colleagues and I developed this initiative, which Jitin mentioned at the start, called the Uganda Initiative for Integrated Management of NCDs. And this has sort of been the home base of my work. And I think, you can read the mission statement. What I'll say, and I think it's important to hone in on, is that from the very beginning, our work has been centered alongside Ministry of Health and academia and civil society in a partnership that I think is often underappreciated or underused in research endeavors, which is really being at the table from the start in terms of all the questions being asked and all the work being done, really being driven locally with partnership. So over the next years would slowly build this evidence base, and no matter what we did, the issues of access to medicines were really front and center for whether we were evaluating patient perspectives or clinician perspectives or looking at the health system performance. Access to medicines was always a sore point. And so then shifting back here, Venkat mentioned Kasia Lipska, who we did this project with a number of years ago, where we looked at cost-related insulin underuse here in the States in our diabetes center at Yale, right? And we asked patients, we defined cost-related underuse or non-adherence as using less than prescribed, trying to stretch out insulin, smaller doses than prescribed, and a number of other things, all because of cost, right? And found that a quarter of patients had cost-related non-adherence to their insulin. And this was consistent with other studies that have been done around the country. And similar to the patient that I talked about, 40% hadn't discussed with their clinician, and not surprisingly, those with cost-related underuse had worse clinical outcomes. So this is sort of the evolution of my own thinking and work, and really regardless of place, the questions that were recurrent around medicines were like, where are they? How do I afford them? How can I get them? Do I trust them? Right? And so this is sort of has been the shaping of my work. So I was going to do an interactive activity. The technology wasn't working out, and I didn't know how many people would be in the room. So I'll just show you. When I've given versions of this talk, I ask and do an interactive thing around what is needed to ensure access to medicines for chronic conditions. And this is just a word cloud from the last time I did this. I thought it'd be easier to not take a chance at the technology. But these are some of the things that people think about, right? And money always comes out front and center, insurance, time, transportation, but, delivery system, refrigeration, corruption, understanding. So it's complicated. And to paint another picture for the complexity, this is an exercise I also do with students when I talk about this. I like to think about this cascade of medicine access, right? So a pill is produced at some factory somewhere on Earth, on the left side of the screen, and has to make it to the patient, right? Somewhere else on the planet. And this cascade is really complicated. And so what I'm showing you again is the result of when I do this with students and we talk about, what are the barriers to access at the production, at the point of distribution. Now you're entering the health system's government, you're thinking about things like essential medicines list and demand forecasting, things I work on with Jitin and Roshni. But then even more proximal to the patient, barriers around the facilities and the providers, right? So is there expertise? Is there diagnostic capability? The geography, location, right? And then at the patient level, things like stigma and adverse effects and costs, affordability, natural disasters, right? So really complicated. And again, we could spend a whole hour just doing this exercise, but I thought it would be illustrative of just the complexity to help us think about the issues that
Jeremy, can I
yeah,
pause?
please. Yeah.
I like this a lot. question in my head is, we are not the only ones who deal with it. Walmart deals with it.
Right.
Coca-Cola deals with it. Pepsi deals with it. You're familiar. So how are they managing to make a product available at an affordable cost anywhere in the world?
Yeah.
Why can't we do it?
Right. So it's a great question, and I can't answer it. I know that Coke, for example, through Project Last Mile, has engaged with health systems. There's some nods who probably had experiences in Ethiopia, right? There was definitely Project Last Mile in Ethiopia and other countries, but trying to leverage the distribution networks, the technology. As for the affordability, that's a great question.
Yeah.
I don't know if people on the room have answers.
I think we also need to learn from how they do.
Yes.
May not all apply, but I think that may be where there are some synergies.
Exactly. So Project Last Mile, to my understanding, was based on the notion that Coca-Cola can get a Coca-Cola to anyone anywhere on the planet, and certainly there are lessons, and I think that's what PLM was based on. I don't know if folks have other comments in this to this question about cuts.
So maybe we should have a discussion with them. If we are struggling with this problem, can you help us solve it?
Yeah.
I say it's complicated because there's so many different issues. The funding for it, the fragmentation. We were at a panel last week and they were saying the supply chain cost of export, and I'm talking about low middle income, it's from 20 to 70%. So it's not just the cost of the supply chain markups. It's all the middle people all along the way, and this is for NCD medicines. But when it comes to HIV, so even for Coke, I'd say lessons learned. Thanks to the funding, or demand forecasting, very tight supply chains, there's a marked difference between that and insulin. So lessons learned from them, from Global Fund, from Coke. We have a lot to figure
and in countries like Uganda, I mean, because of the vertical funding mechanisms, the supply chains actually function completely outside of the supply chains of everything else.
And the reason I'm thinking about this, again, one of the very influential books that I read many years ago, you may all have read it. It's called The Bottom Billion of the Pyramid by C.K. Prahalad. The entire philosophy, he turns it upside down. He says, stop viewing the poor as victims. See them as consumers. So how do you reach, suppose you're a company and you have to sell to make profit by selling to the poor, which is where your market is. How do you price it? And to price it there, suppose you have to price it at, 1/100th the cost or 1/10th the cost in, say, in Uganda, where should the production happen?
Right.
Where should your distribution channel happen? So can you rethink the entire system rather than being stuck in this model, which is expensive, and then we fight our battle about it being expensive? So is there in other words, what I'm trying to push for, is there a market solution for all this?
Yeah. I mean, and these are some of the things that we're tackling in the Coalition for Access that I'll just mention very briefly a little later. But yeah, it's a really, really important point. I might think about bringing Coke or someone else into that. So with all of that as a background, I wanted to use this 4A's framework. There's simple framework, but I think it's helpful to think about. And what we'll do is talk about examples of each of these from both international and domestic contexts. So we'll start with acceptability. So there's acceptability, accessibility, affordability, and availability. Acceptability. I'll spend the least time on this, but these are just some quotations from some of the work we've done around access in Uganda. And a patient seeking care at a public facility said, I already told you the type of insulin is ineffective with severe side effects. It always affected me, and now I just don't want to use it. It doesn't work for us, not me alone. A pharmacist saying the insulin we have, patients are complaining that it's weak. They tend to give themselves larger doses for it to work. So those who can afford, we tell them to look for other brands which are more effective. So these are real issues around acceptability. Obviously, this is a very complex area, with stigma and side effects and all of those very proximal issues that I mentioned in that medicine access cascade, but just to paint a picture. But again, very relevant here in the States too. This is just one example around distrust. Vaccine hesitancy, of course, was front and center throughout COVID, and now in our current political environment will become ever more so. We have measles outbreaks in, I think, 4 or 5 states in the United States. So this is all very real. So that's all I'm really going to say about acceptability. We'll move on to accessibility. So how accessible are medicines to patients where they are? So an important concept, just raise your hand if you know about the essential medicines list, if you've heard about that. Okay, so a number of folks, but I'll just spend a minute, not everyone. So this is an example, a screenshot just from the WHO model essential medicines list, right? In order for medicines to be accessible in the public sector in a country like Uganda, those molecules need to be on the national essential medicines list. If they're not there, they don't make it into the country in the public sector. Where that all begins, though, is with the model EML. So there's a model EML put out by WHO, and I show that to say that there are a lot of opportunities for modernizing and updating the EML. A close colleague, Sunny Kishore, who Ben Ken and I know, has done a lot of work on modernizing the model EML to include newer medicines for cardiovascular disease. So it's a huge area of impact. And then we've had the opportunity in the Ugandan context to think about modernizing the national EML. So we've worked on, even something like replacing nifedipine with amlodipine, a newer agent, fewer times a day, fewer side effects, extending certain drugs to lower level health centers. So if the essential medicines list says that amlodipine can only be stocked at a hospital level, it means that all the lower level health centers don't have access to it, which means that it's farther from patients, right? So this, again, around accessibility, it's a really important thing. So we've been able to drop the lower level health center designation or make some of these medicines available at lower level health centers. And then integrating hypertension medicines into annual quantification and forecasting, right? So again, if health facilities or district managers don't know how to forecast, don't have the tools and data to forecast and quantify, those medicines aren't accessible to patients. Some of the work that we're doing in heart failure, just to mention the mobile health work, I would love to talk more about this. Probably won't get into more detail here, but just to say that decentralization is a huge aspect, right? So if there's, in our context, one center of excellence for cardiac care, for heart failure care in all of Uganda, it's real that means that the care and thus often the medicines to drive to drive that care are located only in that centralized location. So we're doing work on building capacity and then using mobile technology to enhance that capacity for self-care and clinical care for heart failure in hospitals all around Uganda. But it's very complicated. That it's not simple enough, right? If you build the care platform, if you help people be able to take care of patients, let's say with heart failure, it doesn't mean the medicines necessarily follow, right? Pharmacists working at health facilities, a hospital in rural Uganda has a fixed budget for medicines, and they have to, from that fixed budget, they have to make hard decisions about what do they pull from the ministry for malaria and pneumonia, and what do they pull for hypertension. And so a lot of advocacy comes into this, and again, the quantification and forecasting are key players. Shifting then back to the US, right? Pharmacy, this concept of pharmacy deserts. So accessibility is an issue here as well. This is a really nice study where they looked at every census tract in the US and looked at designated whether, I don't have the numbers in front of me, but they identified whether census tracts in red were pharmacy deserts, meaning there was a socioeconomic and a distance factor. And when you look at the Southeast, looks pretty good. But when you zoom in, on Georgia, and this is the case if you look at any state really, this is Atlanta, metropolitan Atlanta. It looks to me like there are many pockets of pharmacy deserts throughout the state. But if you zoom in on Atlanta, like still right within where we are, there are pockets where accessibility to medicines is low. So I think it's just important to recognize, right? This is an issue here as well for many of the patients that we take care of. So shifting from acceptability and accessibility to availability. So I'll just show you some of the work we've done over the years in Uganda, specifically on availability. So this was a study where we looked at 10 essential medicines for NCDs. and looked at the percentage of public facilities in which they were found. And about 40% had none of these key essential medicines, while none of the facilities had all of them, right? And there are limitations in these data. They're often cross-sectional, and we know that supply at pharmacies is variable and dynamic. But just again, to paint a picture that this is this is really what folks are dealing with is low availability of these medicines. We also know that, as I said, it is dynamic. And so we looked at a 5-week period and collected data on availability of these medicines in public, private for-profit, and not-for-profit sectors, and showed a lot of variability, changes in availability over time of some of these essential medicines for chronic disease. Some quotations from some of our work in this space. So a female patient in the public sector saying there are times when we spend about 2 to 3 months without receiving medicines. Like by the end of last month, we had spent 2 months without receiving. Another patient said, what brings more problems is when the test strips are out of stock, right? So not the medicines, but the products. Yet it's a must. We have to take the blood test before we get medicines, and the doctor won't work on you before your blood is checked, right? So a lot of gaps, and therefore a lot of opportunities for improving availability. And I mentioned the coalition. This is just to point out that some of our work has been focused on developing a forecasting tool for diabetes and hypertension medicines to be used in countries like Uganda, and it has been piloted and used even more extensively in some other countries, and is now, as we were talking about a little while ago, with WHO, which is trying to build upon it and implement it in the global setting.
Tell me, who's funding your research?
So it's been different. So I have NIH is funding the heart failure and a mental health project, really in the digital health space. The work specifically on access has been smaller projects, and then the work I'm doing with the coalition. So again, shifting from the Ugandan context back here, availability is a major issue here as well, right? This is just a screenshot around the impact of the recent hurricanes, leading to shortages of IV fluids in hospitals all around this country. Ozempic, among others, right? Massive shortages. The why, right? There's cost and supply chain, but also demand surges, right? Stimulants for ADHD, major shortages over the past few years, right? So availability is also an issue locally.
So is it a manufacturing problem or a raw material problem?
Or a what problem?
Raw material.
Yeah, so my understanding, like to take the Adderall example or the stimulants example, is that this really started to take off during COVID with social isolation and a lot more adults being diagnosed or seeking care for ADHD. So a real surge in adult use, and so coupled with supply chain problems have led to like an extended shortage.
Why can't, just thinking, why can't a manufacturing factory be established in Uganda?
Can actually there are. I mean, on the continent there are there's more and more local production, but it's still fairly nascent. A lot has been focused on vaccine, but
maybe that's the ultimate.
Yeah, no, that is certainly part of the solution. Yeah,
I think part of those things hinge on political stability, safety, security, access to materials, and a lot of the social things, right?
It's chicken and egg. This might solve that.
Yeah.
I'm with you.
Yeah. So let's shift from availability to this last A, so affordability, right? Which is a major issue, and this is the sort of what the case I introduced is centered upon. So again, some of our work in Uganda that has looked at this has shown, so the medicines each in a different color, some for acute conditions, most for chronic conditions, looking at the range of price in the y-axis, and just over a 5-week period showing that some of these medicines had quite large ranges of price. And so that, for folks on fixed limited incomes, posed major affordability challenges. A prescriber in a public hospital in Uganda saying some patients come back after a month when they did not buy the medicines we prescribed. Genuinely, some can't afford them because they don't have the money. And I've seen them. You find a patient has not been getting any medicine from the previous 4 visits. he doesn't have the money, and the patient tells you, fine, let me go home and die. And, you know, a striking quote, but not all that dissimilar from the case we talked about at Yale New Haven, right? Or I'm sure here in Atlanta as well. A patient saying, I didn't have medicines because I'd spent 2 months without coming for treatment. I couldn't afford the transport to bring me here, right? So again, like the complexity of access. So this is around the indirect costs of the medicines, right? And again, to the importance of decentralization, of bringing care and supply closer to where patients are.
But we're cutting your indirect costs.
Right. Yes. Yeah. Yes. Thank you for that. I think just, you know, a moment to say, you know, when it comes to affordability and availability, PEPFAR, you know, the President's Emergency Plan on AIDS Relief in Africa, you know, was a blessing and a curse, right? So created, as we mentioned earlier, this parallel infrastructure, high functioning infrastructure upon which so much leveraging has taken place, but also left huge gaps, right? So patients would rather have HIV than hypertension, right? Because of the access to care and medicine. And created this alternate universe in a way for patients' experience, where people assume that care was free and available all the time, and that just isn't the case and probably not sustainable for most countries.
I was going to ask you that again in the current debate. How much dependency did we end up creating?
A lot. I almost took this slide out. I just thought we needed to have it here to recognize like the moment we're in. So PEPFAR needed to go, in my opinion, PEPFAR needed to go away. The way it has come about, I would say.
Maybe there's a lesson here for the future, is that when you start these things, there's got to be some sort of a phased
Exit strategy.
Oh, yes. Yeah, for sure. That would have been the humane way to do it. I think everyone saw the writing on the wall for PEPFAR, but not in the way that it was done. We could, again, spend much more time talking about that. But so shifting back to domestically and affordability. So affordability is not just around can people pay out-of-pocket costs, but can systems pay the cost of the medicines, right? This is just some recent news articles nationally and then in Connecticut around how, you know, some of these newer medicines for diabetes, which after so many years of stagnation, we now have all of these treatments, but the costs are outstripping the ability of systems to pay, right? And so in Connecticut alone, these meds costing $60 million per year just for the state-funded health plan.
So what happens when they become generic? You just done estimates of when they'll become generic?
Yeah, I know there actually is. There's one GLP-1 that's generic already, right?
Is there? There's one becoming in India next year. I know that.
Okay, I don't know, but I'm sure that will help the situation. But the degree to which the demand is outstripping the ability to pay is pretty staggering. You know, and then the complexity of, are these medicines approved for diabetes or for weight loss? And in some states, you know, state Medicaid can cover both. In many states, they can't. So it's a complex landscape.
Again, this is something. Just sorry for asking
Please,
this
this is
again.
great.
Have we done modeling in modeling? Because many of these drugs, okay, they're going to be not one-time users. They're going to be like long-term in the future. So depending on how long people are going to use the drug, have you looked at whether if companies are smarter with lower costing now, lower pricing now, would they reap benefits into the future? Those kind of scenarios.
Yes. I mean, I would think, right, this is a balance for these state programs, at least, it's a balance between reaping long-term benefit on saved healthcare costs versus, right, so if the price of the drug was lower now.
How you negotiate with the company, you know?
I thankfully have no role in that, but
you don't have a role in that.
But it's an important point. So, you know, shifting to out-of-pocket costs, where a lot of our work has been focused, is where we'll go now. So I already showed a derivation of this same statistic earlier. You know, U.S. out-of-pocket prescription drug spending, as we know, is sky high, and because of that, many people saying that they're not taking their medicines as prescribed because of cost, right? And that most patients prescribed a medication don't ask their doctor for a lower cost alternative. Yet as clinicians, we do feel obligation to address costs with our patients. A colleague of mine at Duke had done this nice study of 900 physicians in this country and asked about their obligation, their sense of obligation to initiate cost conversations, which most providers felt they had. But most also had a hard time advising their patients about out-of-pocket costs. And barriers were insufficient time, knowledge, discomfort. But most of them did think that their patients expected them to solve or at least address the cost-related issues. Right? But we're really bad at it. We have difficulty accurately estimating out-of-pocket costs, even when we have access to the patient's insurance plans. And why is that? It's because our system is so complicated. So this is just a schematic showing, you know, the cascade here from drug maker to wholesaler to pharmacy, and then this middleman who stands between the pharmacy and the consumer or health insurer called the PBM. They set the price, right? So knowing what insurance a patient has in this country is not necessarily helpful, and there are so many plans, it's really impossible. So we'll spend the rest of the time just thinking about our domestic challenges around out-of-pocket cost estimation and how we work with patients in that space. And this is work that I've done with Dr. Kashyap and others. So we have this toolkit as clinicians. We have discount cards and retail pharmacy discount lists and online estimators like GoodRx or Amazon Pharmacy is another program. Some providers will give free samples. And then there are tools, electronic tools that are embedded in our health record. Just to say, like, all of this is a Band-Aid for a very broken system. But given the broken system, some of these tools become the lifeline, and they're important to know how to use and to implement well. So I just flew through that list, but these are examples of discount cards that might come to a patient or a doctor offering discounts on medicines. Walmart, Walgreens, they all have discounted drug lists. You can go to these price comparison tools like GoodRx if you don't have insurance or if your patient doesn't have insurance, and type in Ozempic and you can see what the out-of-pocket cost is for a month. Right? There are direct consumer pharmacies, so trying to take out the middleman. Mark Cuban, Amazon, trying to do this in different ways, right? So a lot of Band-Aids on this systemic issues. Some patients, just as an example, take to crowdfunding, right, to crowdsource money for medicine. I'll spend most of my work, though, has been focused on these EHR-based tools. This is an example of sort of a former generation of a tool that is embedded into our electronic health record, where you go to prescribe a medicine and you'll get some information about if it's on the preferred list for the patient's insurance plan, or sort of relatively what's the copay, but you don't really get granular information. So for me as a clinician sitting with my patient, to be able to have a conversation about like, what is this actually going to cost you is very challenging. And so that's where we come to this new generation of tools called real-time prescription benefits. And these are point of prescribing tools. So the notion here is that the point of prescribing is an opportune moment for clinicians and patients to discuss out-of-pocket cost. And for clinicians then to potentially modify the cost or the prescription accordingly. But there's this lack of transparency that we talked about that limits the potential to do this. And so these RTPB tools showed patient-specific out-of-pocket estimates and suggest lower cost alternatives by using data directly from that middleman, the PBM. That's the idea of these RTPB tools. And importantly, the Centers for Medicare and Medicaid Services, CMS, has mandated for the last 5 years or so integration of these tools into electronic health records. So how does it work? So basically based on the patient's insurer and the PBM, the tools automatically assess eligibility and shows the out-of-pocket cost and any appropriate alternatives before the prescription is sent to the pharmacy. So here's just an example of linagliptin, a diabetes medicine, and then the system is showing alternative drugs in the same class and different costs and different potential pharmacies. And you, in the moment, can have a conversation, think about this with your patient, and make an educated decision. We wrote this paper in the Journal of General Internal Medicine a couple of years ago. along with Nitu and others, where we help sort of clinicians understand like what does this actually look like and how do these systems work. The rollout of these RTPB tools in this country has been pretty good, but certainly not 100%. So the blue, these are data from about 2 years ago. The blue and the green is basically health systems that have implemented these RTPB tools. So, you know, as of 2 years ago or so, it was right around like 65%. But what I'll talk about in a few minutes is that the way that systems have implemented this has been very variable, right? So there is some data on RTPB tools to date. So most patients, when surveyed, were comfortable or neutral when asked about whether they want their physicians to use a tool like this. We have some evidence around cost savings. There was one large cluster randomized trial in New York that showed an 11% out-of-pocket cost reduction when comparing these tools to usual care. The savings were higher for higher cost drug classes. And importantly, we talked about that non-adherence, right, or the primary non-adherence. If I prescribe a medicine and you don't even pay for it because the cost is so high, right? And this study showed that these tools were associated with a higher prescription fill rate. So we've done some work. I had to do this to you with colleagues in Wisconsin and Hopkins and at Yale, trying to understand how does utilization, what's going on with utilization of these tools. And at Yale, we led the qualitative component, really trying to understand barriers and facilitators to using these tools. So just very briefly, in the quantitative arm of this study, we looked at over 6 million patient encounters with medicines prescribed in a third of them, and the tool firing or displaying alternatives in about half of those cases, but clinicians selecting alternatives in a very small percentage. And this was across the health systems and really comes back to what providers know or trust in using these tools. And so it was really based on this low utilization rate that we wanted to delve deeper with some qualitative work. We looked at utilizers and non-utilizers and recruited a purposive sample across these institutions. We interviewed 43 clinicians of diverse specialties, physicians, nurse practitioners, PAs. And there were 4 emergent themes, and I'll show you some example quotations from each of these in the last part of this talk. So these are the 4 themes, and I'll go through them one by one. So the first theme was that clinicians feel hampered in their ability to provide the best quality care because of high out-of-pocket cost burden. This was a clinician at Yale saying, I've said this many times, it's unconscionable that we can't provide patients with the best medications because it's cost prohibitive. And somebody makes that decision, not us. And in this day and age, I think it's absolutely wrong. I understand R&D, I understand pharmaceutical companies need to recoup the cost that it took them 10 years to get one drug on the market, but I don't understand having to go back to drugs we've had for 10 years when something is much better now. Another clinician saying, the issue that I have is that my patients, even if they're covered by insurance, the drugs are still very expensive, to the point that most patients can't afford them. And it winds up being me saying, I have a medication that can prevent death from heart failure, for example. It's going to cost you $5,000 a year, even with your insurance. So I have patients literally telling, I can't, sorry, it's not for you. So it's really been a lot of moral fatigue from that standpoint. And again, thinking about like some of the data and quotations from Uganda, like a lot of striking similarities, right? So the second theme that came out of this work is that clinicians and their staff have developed labor-intensive informal systems to generate price checking and cost mitigation strategies. So I showed you that toolkit, complex toolkit that we have. And a clinician at Johns Hopkins saying, depending on the health insurance provider, it seems like every year when they're changing the pharmacy panels of drugs, I'll get hit with a bunch of requests from the insurance company saying they won't cover something that they've been covering for the last 12 months. And then I switch to whatever they want me to switch to. And then the same thing happens a year later when they want you to switch back to the original. Another clinician saying, it's catch as catch can. The rules change all the time. It's an inordinate amount of time spent on almost every patient these days. I often find that the nurse I'd like to speak to about a different patient issue is on the phone for half an hour with an insurance company or pharmacy trying to negotiate a price for the patient. And I'm thinking to myself, what's wrong with our system? So those are, some of the sort of more general issues that came out around dealing with cost and practices. Now just focusing on the last two themes are really around the use of these tools. So some barriers to RTPB utilization include perceived time burden and lack of awareness and training. And so a clinician said the tool pops up right at the point of prescribing, so you're going to change the prescribing decision at that point. You have to kind of stop and go back to the patient with this new information. That can be challenging, having just had a conversation. And then going back, and in terms of the cost analysis, saying, oh, well, wait a minute, there's this other idea after you've just tried to convince a person that this is the right medication to use. Another provider saying, I can honestly tell you that I've been part of the care pathway group for outpatient diabetes. And one of the physicians in our meetings talked about, I think it's the tool you're mentioning right now. And I sat here saying, just as I'm saying now, I have no clue about this tool whatsoever. And therefore I've never used it, right? So really speaking to how these systems are implemented and do providers, clinicians know how to use them? Or these were some of the barriers. And so for the final theme out of this project, the accuracy and reliability of the displayed out-of-pocket cost data are critical facilitators to adoption. And so this clinician saying for the majority of times, the tool comes up as unknown. It'll say unknown instead of a price. They said, I have had very limited data coming through on patients when I've used these tools. And to be honest, it got to the point that I was using it and checking in to see if it would help me. And I gave up using it because there was never any data. Always says unknown. Occasionally it'll come up with something and give you a price, but that's a small percentage of the time. Another perspective, the final quote I'll share, saying if a tool popped up and told me exactly how much it costs before and after insurance for certain patients, I think that would allow me to both make better decisions, but also have that discussion with the patient. Because I do think it's a bugaboo for our system and for the patients, right? So it's a nice quotation to end on here because this clinician picked up on this key aspect, which is that the tools, if they're going to be used properly, not only have to be accurate and reliable, but they have to allow for conversations with the patient. So to summarize this work on RTPB, having the potential to promote out-of-pocket cost conversations at the point of prescribing and take action towards lowering these costs. But health systems have to train providers. The cost data has to be accurate and reliable if they're to be trusted and used. So I wanted to just return to that original case where that patient with diabetes and ulcerative colitis was saying it was either food or insulin, right? And I hope that in this discussion, you're coming away with an appreciation for a way to think about access to medicines, but that this is important whether we're thinking about this on an international stage or here in this country. And then a lot of the issues and challenges faced globally are also faced domestically. And that's sort of been the theme of my own work. And I think it's important for all of us to sort of be cognizant of that.
We try to quantify that similarity.
So say more.
So like, for example, I agree that it exists in both places. Yeah. How big is the problem in each? It might be equally big. But trying to quantify it might be very powerful. Yeah,
it's a good question. I think so. Our lab called the Global Chronic Care Access Lab is really trying to do that, to bring study to both domestic and international contexts and build bridges where they might not exist. And with that, I'll end. So thank you.
CDC, when we measured initially in the late 90s, the quality of diabetes care in the United States,
yes,
we were shocked that less than 10% of the US population with diabetes had good control of glucose, blood pressure, lipids. Yeah. And what struck me in the next several years, once we published that study, everybody was trying to do it, that across the world, you go to poor Bangladesh or you go to, it was similar.
Similar, yeah.
So the idea that we are spending a lot of money doesn't necessarily translate into better quality.
Into better outcomes. No. And I think that's been shown at multiple levels.
Yeah.
I'm happy to take questions. I see Felix, you have your hand up.
Sure. Thanks so much for the great presentation. Yeah. Can you hear me well?
Perfectly, yeah.
Okay, perfect. Yeah, thanks so much for sharing your work. A lot of it resonated very strongly with me, and I think many people in this room who worked on chronic disease care in global setting. And I also appreciated Venkat's various comments where he already was thinking out loud about potential solutions about this. And yeah, I actually, together with Mo, wrote a commentary about this last year, where we also suggested some of these great low friction solutions, such as differential drug pricing, public-private partnerships, pooled procurement, and so on. But to be quite frank, I've grown increasingly skeptical or cynical over the past couple of weeks about how things work out in the world. So a cynic might argue that by now Eli Lilly, Novo Nordisk, all these big companies had ample time to prove that they are aware of the global epidemiology of diabetes and other chronic diseases and take decisive action to increase access, yet that has not really happened. So I guess my politically very charged question is, isn't the only thing that might be a true promising fix here to just be top-down governmental interventions and market regulations?
Well, we're seeing the power of top-down right now. I think it's a great point. I will welcome any other comments. I mean, Roshni, not to put you on the spot, but through the coalition, you engaged closely with biopharma. Are we seeing any changes in the way that these discussions are happening around access?
It's actually, it just feels so complicated. So in a session last week that Novo Nordisk actually held on healthy market is what they're calling it. It's interesting that the issue actually for insulin access in many of the low-income countries, low-middle-income countries, is actually not price. So the problem was because they have so many access programs, the price is so low that other manufacturers don't want to come in. There's just not enough of an incentive. And now with GLPs, etc., there's a lot of interest in actually moving straight to other products than insulin. The issue of local manufacturing was brought out. The interesting thing is it's much cheaper to get product from India, for example, than it is to try to do it local manufacturing. So they need government support, but then you have stockouts. So you need government support to actually say, we will support our local manufacturer rather than, others. So it was interesting because we always think it's the price of the product, but when they said the price of the product is X, and then you get 20 to 70% transport costs, you don't have cold chain, you have distributors. It's how do you begin to solve this problem is then much more complicated than price. So no magic bullet and no answer really to it, to just say it really does take a lot of different players coming together, from government to private to actually implementing partners.
I appreciate that. I just was going to go back to one slide that I breezed over earlier, but this is an issue or a question that's raised here too, right? Like are shortages driven by actually lower price? Yeah. Great. You had a question?
Yeah. Thank you for the presentation. My question is, maybe have you ever seen this issue together with diabetics associations? If there is any association, for example, all DM patients, maybe the National DM Association and the like. So is there any mechanism to make, to solve the affordability issue through the, because it's one big association, it's a big one, it's a common problem. And there are a lot of ways how to tackle better with different, agencies or funding organizations. Have you ever considered this?
So you're speaking of civil society groups, like
especially the DM
Uganda Diabetes Association. Yeah. So that's a really great question and point. I will say, based on my own experience in this space, in Uganda specifically. So there is a lot of momentum around patient-driven support groups that use like fund pooling mechanisms. So this isn't at the level of like the National Association driving for lower prices, but more at a local level of patients pooling funds and using those to procure, lower cost and more stable supply of medicines. So we're doing work to try to understand the landscape and what these groups actually look like, because they're parallel to the health system. They're not integrated within. So I think there's a lot of interest, at least in Uganda, on these sort of innovative approaches to try to drive down price. But that notion of these patient-driven support groups came out of the Uganda Diabetes Association, and their creation was really around diabetes initially, and is now branching into other NCDs. Yeah. Yeah.
Do you have a comment to add those two questions together? Just as an example, what happened in Connecticut was through advocacy from government channels and maybe a comptroller or two, as well as medical societies, insulin was considered one of those important medications that then there was a mandate to put them on the PDMP, right? Does that actually do much to affordability or cost? But it did bring the attention. And yes, the rest of us had to work a little bit harder to get it to the PDMP. Mm-hmm. But it can have an impact, but it could also be very lopsided in some ways.
Yeah.
Because their interests are so focused.
So focused, yeah. Yeah, interesting point. Thank you. So I think we're at the hour. Yeah, a few other comments or questions?
Yeah, I work a lot from the health behavior side of things and talking to patients, and it's interesting hearing all the gaps and inconsistencies that can feed to access issues to medication. A lot of what I hear is once people have been prescribed a medication, they no longer have to adhere to lifestyle change because the medication will solve that issue. They don't have to watch their diet, they don't have to exercise, that will be accounted for. But when you have these, gaps of 2 months where you may not be taking medication, and recognizing that, does it change, I guess, your perspective on how counseling and education looks like from a clinical perspective, knowing that maybe some of these beliefs and attitudes towards medication?
Yeah, I think so. It's so interesting. I would love to talk more about this. I mean, from the Uganda perspective, and which is also relevant here, thinking about how and when patients engage with traditional healers and use herbal medicines, right, which play a huge part in chronic care. The systems are so disconnected, and the way in which patients, like when and whether they use herbs or don't use herbs, is so variable and depends on supply and affordability and accessibility, but also side effects and perceived side effects. So that's a really fascinating area. I think, relevant domestically too. Yeah, thank you for bringing that up. Was there one other? Great. Well, thanks for being here and for listening, and thanks to those of you online. Appreciate it.
Thank you.